So much for the introduction. As mentioned, I'm Sarath Raju. I'm a pulmonologist, so I speak about a lot of things primarily from a pulmonary perspective. I'm going to talk a little bit about current evidence-based practices and guidelines for people living with HIV and COPD. And I kind of use this title today because it was actually suggested to me from a previous talk, but it's a bit of a misnomer of a topic because of a title because if I just did purely evidence-based practices for people with HIV, we're actually excluded from a lot of COPD studies to begin with. So a lot of what we do is sort of applying what goes from the general population to people living with HIV. But I'm going to try to give you a little bit of HIV-specific considerations. In the interest of full disclosure, I am going to make a plug as well for our ongoing study at the end of this talk. So just you'll see that coming. Just some disclosures. I do have some grant support from a pharmaceutical company. I'm not going to be discussing that today, and it's not related to the topic at hand, but just to mention that up front. As far as my objectives today, I'm going to talk a little bit about describe the prevalence of COPD amongst people living with HIV, and describe why I think it's an important consideration. Define current methods for assessing COPD severity, utilizing the most recent guidelines from the Gold Society, which is one of the societies we look at in our care for COPD, and provide an overview about the current therapeutic approach for COPD in the general population, describe treatment considerations for COPD amongst persons living with HIV. I'm going to talk a little bit about this in the setting of a case of an individual I saw not too long ago. So this is a 65-year-old African-American man who presented for ongoing chronic progressive shortness of breath. He had a history of HIV, MGUS, recurrent pneumonias. And it's noticeable he's very visibly short of breath. So we walked him in the clinic. We found out he was satting about 92 at rest, but he quickly desaturated to 83% with ambulation. So notable exertional hypoxemia. Prior to this, he'd been on inhalers, though he hadn't been formally diagnosed with COPD. So he was on the brand name is Trilogy, but it's a LAMA/LABA ICS, so two bronchodilators and an inhaled corticosteroid. He didn't describe any exacerbations or rather events where he required oral steroids to treat his pulmonary issues in the past. And he'd actually had a CT prior to seeing me, as a lot of patients do from the ED and other sources. But essentially what his CT revealed was you'll see a lot of black holes throughout the lungs. So he had a lot of emphysematous changes throughout his lungs that was sort of consistent with his presentation. And describe some of his related exposure. He has a history of HIV, diagnosed in the 90s. He had a 30-pack year smoking history prior to cocaine use. So labs revealed 3% eosinophils with an absolute eosinophil count. That's what that acronym is for, is 300. I mentioned this up front, kind of stands out, but it'll be related to how I talk about our therapeutic approaches later. He was on Biktarvy for his ART. His viral load was undetectable, though he had a very high viral load not too long ago. He had a history of recurrent bacterial pneumonias, but no history of PJP as far as we knew. And he had a lung function test with this surrounding this clinic appointment, and I'll walk through what some of these mean. The biggest thing we often look at is a measure from the first part of the lung function test called spirometry, which is where we look at the FEV1 to FVC ratio, or the forced expiratory volume in 1 second over forced vital capacity, which measures the rate of how quickly you get air out of your lungs. People with the lower rate are obstructed. So his actual FEV1 to FVC ratio is 62, which fits in the category of obstruction by multiple criteria we'll go through. I'll also point out that his diffusing capacity for carbon monoxide, or DLCO, was also very low at 23% of predicted. And I'll point out that the DLCO is the measurement that most correlates to how much oxygen you may need. So just giving a quick primer of how we look at lung function testing. We utilize this FEV1 to FVC ratio, which tells us about obstruction if it's low, which means a low rate of getting lungs out of your air out of your lungs. People with obstructive lung disease have slow emptying. A high FEV1 to FVC ratio could be either normal or restricted. COPD itself is characterized by irreversible airflow obstruction. So even after you give someone an inhaler, they are still obstructed. Um, the measure I pointed out was a flow volume loop. So this is an expiratory loop where as people breathe out, the air goes out slower during the expiratory limb as their airways collapse. We grade the severity of airflow obstruction based on the percent predicted of FEV1. And I'll talk a little bit more about that, but he would have fit in the category of a mild airflow obstruction. So essentially, putting this together, this is not a diagnostic mystery by any means. This is a gentleman with COPD with a mild airflow obstruction and a severe gas transfer defect based on his DLCO. And the picture consistent with COPD and emphysema. I want to make a point to emphasize this DLCO impairment because it'll be relevant to some of the factors we talk about a little bit later today. So this brings us to the topic, and I'm going to start off, and as I mentioned, I'm going to start off by talking about how we look at COPD in the general population and why that may be relevant for people living with HIV. So we use the GOLD guidelines for a lot of our care and management of people with COPD. The GOLD guidelines typically characterize COPD as a common, preventable, and treatable disease. With related to significant exposures, particularly smoking and abnormal pollutant exposure that may predispose you towards lung disease. In more recent guidelines, we've emphasized that COPD is actually a very heterogeneous disease. It can be characterized by shortness of breath, cough, sputum production, and there are multiple presentations of it, including more of a bronchitis or an emphysematous picture. And it's often related to complex causes and gene and environment interactions, your reactions. And we've come to emphasize it's related to exposures over an individual's lifetime that leads to the development of lung disease today and later in life, as COPD is often a disease of lung disease developed amongst older adults later in life. And this is a complicated cartoon that sort of demonstrates the point where you go through the maze of life on the left, where the factors that contribute to COPD range from your birth-related factors to prematurity, early life nutrition, to smoking exposure from secondhand smoke, air pollution exposure, and other factors, early life infections that lead to where you are later in life, where you ultimately might develop COPD. And as mentioned, those risk factors may be smoking exposures, individual socioeconomic status, early life risk factors, and other external environmental causes that can lead to the development of COPD. So we've come to emphasize that COPD is multiple processes in life lead to the development of COPD later in life. And there are varied presentations of COPD. While it's historically characterized by airflow obstruction on PFTs, the clinical and radiographic manifestations can be pretty heterogeneous. Historically, as you may see on the animation, on the cartoon on the left, there are these like pink puffers and blue bloaters people talked about, which could be an emphysema or chronic bronchitis. Now those are thought of as just, we've described more phenotypes of COPD than I can even name right now, and where we've sort of learned that the presentation can be extremely heterogeneous. Even radiographically, we can see people with severe COPD who have no emphysema to a lot of emphysema and varied presentations. And how does this, in terms of we're thinking about the manifestations of COPD, how does this relate to people with HIV? And talking about emphysema in particular, some very early studies, particularly in the pre-antiretroviral therapy era, describe the presence of emphysema on CAT scans of people with HIV early in life. And this is from a report from the Annals of Internal Medicine that came out a couple of decades ago now, looking at CT scans of young individuals in their 30s with some smoking history, but not significant enough to where you would think they would develop severe emphysema, but some of which had poor control of their HIV, and where we saw a higher incidence of emphysema in this subgroup compared to match control. So this ended up being one of the earlier reports. Since then, systematic reviews have described a higher prevalence of COPD in HIV populations. This is from one study, which is a little bit older now, from Lancet Global Health, describing a prevalence of 10.6% amongst those with HIV versus 6% in the general population of adults above the age of 18. I will say in our local Baltimore cohorts, SHIELD or the Alive cohort being one of them, where there's a high prevalence of smoking. In that cohort, the prevalence of COPD is about 20%. So it can be highly common, even whether that's related to HIV itself or associated risk factors, that still needs to be teased out. There have been some mechanisms for describing that have tied HIV to chronic respiratory disease, both related to immune dysfunction and direct lung damage. The figure on the right describes some mechanisms within the lungs that have tied HIV itself to the development of multiple lung diseases, including HIV living as having a persistent reservoir within the lung, epithelial barrier disruption, which can lead to emphysema. There's also additionally found to be an upregulation of matrix metalloproteinases, which actually have been directly implicated in the development of emphysema, in addition to alterations of other inflammatory cytokines. And this phenomenon has been recognized to the point where in our more recent GOLD guidelines for COPD, they've described etiotypes of COPD from different causes, and they've even created this category of COPD-I or COPD due to infections. One subgroup within that is individuals with HIV and COPD as well. Bring recognition of this to the greater community of people taking care of COPD. So now that we sort of talked about diagnosis, epidemiology, and prevalence, I want to talk a little bit about grading severity of disease, because that'll bring into account our treatment considerations. Spirometry, or that lung function test, is still the gold standard for diagnosing COPD. There are different criteria people use based on the FEV1 to FVC ratio to characterize airflow obstruction. Some people utilize a number called the lower limit of normal, which is the bottom 5th percentile for individuals in that age group. Other people do that based on less than 70%. I will say, in my mind, if someone is symptomatic with the appropriate history, if they meet either criteria, I consider them obstructed. And then we categorize severity of airflow obstruction based on their FEV1 % predicted. Now, what we've recognized is that these lung function values correlate pretty well to things like mortality, complications after surgery, but they don't correlate that well to symptoms. And they don't really give you that great of a guideline on what to do therapeutically. So actually how we assess therapy in grade severity is transition more to using this GOLD A, B, and E category, which recognizes two different important factors in symptomology. One is there are certain individuals whose COPD profile is more driven by shortness of breath or cough and phlegm on a daily basis. Those could be your GOLD B individuals. And then there are certain individuals who are driven more by exacerbations, discrete events that are characterized by an acute change where you may have more cough, phlegm, or sputum production, or things requiring prednisone or other therapeutics to calm the disease. And our therapies target those separately. And whether you have GOLD A, B, or E COPD, meaning E being those who are more likely to exacerbate, does not really correspond that well to your lung function. And in grading someone who is symptomatic as B or E. We have the guidelines recommend someone with a MMRC dyspnea score greater than 2 or a CAT score greater than 10. Now, in practice, we don't usually go through that formally. I try to get at the symptoms of significant dyspnea pretty quickly. Essentially, someone who has trouble doing their ADLs or tying their shoes or getting dressed is an MMRC or 4. They're the most symptomatic people who have trouble keeping up with people their own age or shortness of breath on a daily basis are an MMRC of 2 or greater. And those are usually the two questions I ask to get a sense of if they have significant shortness of breath. The COPD assessment test, which is also utilized to characterize significant symptom burden, is just asks about questions about cough and phlegm and shortness of breath that may impair your daily activities, which are, I think, fine enough just to go through in a regular history. But you may have some individuals who are not that symptomatic, but may exacerbate more commonly, and then they'll have discrete episodes of shortness of breath. But as we'll walk through, there are different therapeutic points to start depending on what your disease profile is at baseline. And there's a few different goals for treatment of COPD. One is to reduce symptoms, and the other is to reduce risk for exacerbations and mortality. And things like inhalers, pulmonary rehab, oxygen, smoking cessation are important pieces of that. Um, And I'm going to mention that the majority of this talk, I'm going to spend talking about medications and management. But I mean, obviously, I have to emphasize that, smoking cessation is obviously the most important therapy. This is from a pooled analysis of the NHLBI cohorts that looks at trajectory of lung function as measured by the FEV1 over time. As you age, everyone's lung function goes down. Uh, the groups in red are the groups that smoke. Even those with where it's considered a low intensity smoking, less than 5 cigarettes a day, have a significantly more accelerated decline in lung function. So regardless, in terms of disease maintenance and care for COPD, alongside other comorbidities, smoking cessation ends up being the most important part. And we've actually seen this in HIV specific cohorts, and this is among smokers from the Copenhagen comorbidity cohort, where they observed a synergistic effect of having HIV and smoking and accelerating lung function decline. This hasn't been teased out in other populations, but suggesting their data suggested a potential synergistic effect between the combination of active HIV and smoking exposure leading to lung function decline. But I'm going to transition to primarily talking about therapeutics and management strategies. Now, I will mention 2004 was the first year in a long time where the FDA approved 2 new drugs for COPD. So I'm going to spend a little bit of time talking about that so you're aware of that. But I will mention as I go through this that people living with HIV were excluded from almost all of the current COPD treatment trials. So some of the recommendations I'm making are based on evidence in non-HIV populations. So our standard guidelines have recommendations for treatment based on where you start symptomatically. If you're someone who doesn't exacerbate and you're not really that symptomatic, even though you have gold A COPD, you can just be on a as needed bronchodilator or any medicine that will open up the airways, like an albuterol. For the gold B individuals, they've started to increase in evidence on combination therapies with either a single bronchodilator, like a long-acting beta agonist, or a long-acting muscarinic antagonist. And we have a lower threshold to use dual bronchodilator therapy, which I'll talk a little bit more about. For people who are exacerbating, who've had 2 or more exacerbations that year or a hospitalization leading exacerbation, we push people to at least to be on dual therapy for bronchodilators. So before I talk about the evidence for this, I do want to emphasize that there are a large number of inhalers available. Every year, there are more that become available out there. this figure keeps growing as pharmaceutical companies find different ways to combine medications or make new inhalers. Um, I'll talk a little bit about drug delivery systems as we emphasize, but just, I think every year there's more and more medications that become available to address COPD. Historically, the bread and butter have been these long-acting muscarinic antagonists. Incrusa you may see as a common one. Spiriva is a common one as well. There's inhaled corticosteroids, which can come isolated or in combination. Um, I would say this is fluticasone is a common one. I will say this is people with HIV is maybe end up being a unique population where we see a higher use of QVAR or beclomethasone. We'll talk about reasons for that in a little bit. And then there are combination meds that can be a combination of long-acting beta agonists, a bronchodilator, and inhaled corticosteroid like Advair, Symbicort, or Brilinta. And then these now are the most popular medications for people with COPD, which are either the dual or triple therapy, which could be a Norolipta or Stialto, which are Alama and Alaba, which are dual beta agonists. And I apologize in advance. I forgot to mention that there's going to be a lot of acronyms and alphabet soup throughout this talk. And then Trilogy and Breztri are what we call our triple inhalers, which are becoming more popular, which are the combinations of two bronchodilators and an inhaled corticosteroid. And in the growing guidelines for COPD, there's been a bigger push towards utilizing dual bronchodilator therapy with LAMA and LABA, for people who are symptomatic with COPD, particularly when it impairs their quality of life. And that is just because there have been a growing number of systematic reviews that have shown superiority of these medications in improving lung function and COPD-specific quality of life. So we have a lower threshold to actually start our symptomatic patients on these dual bronchodilator therapies, particularly in individuals with moderate to severe COPD and who are symptomatic. And that is often, and so the framework I was describing was how do you start therapy? And the question becomes next is, once you start someone on therapy, how do you follow up their therapy and how do you step that up? And then when we make decisions on that, we really do base it on what is their driver of symptoms. What is their driver disease burden? Is it shortness of breath or is it exacerbations? Because there's going to be two different paradigms. And I suggest you guys refer to the GOLD guidelines if you have questions, because this is actually updating quite regularly. When we think about this patient in particularly, he was someone who was more driven by shortness of breath. And I'll emphasize a couple things. One is if someone has shortness of breath on a dual bronchodilator therapy with a LABA and a LAMA, if their symptom is primarily shortness of breath, one of the first considerations is actually potentially switching their inhaler device to get something with better drug delivery or making sure they're actually getting their medication effectively before adding new medicines. And what does that mean? So the goal of each of these inhalers is to get medication to your alveoli or the distal aspects of your lung. And there are multiple drug delivery systems with inhalers to do that. They're the propelled meter dose inhalers, which are going to be your most common rescue inhalers like albuterol. They're dry powdered inhalers, and they're slow soft mist inhalers, which I'll show you a few examples of, and nebulizers as well. And one of the most important reasons that this isn't, there are a few reasons this is important. So it's hard for me to count the number of times I've seen referrals in my clinic who I get referrals for advanced care for, even from other pulmonologists. And it's simply that the individual or the patient is not using their inhaler correctly. And studies have shown with improvement in lung function after just proper inhaler teaching, they can get a 150 cc improvement in their inhaler use, and reducing inhaler errors improves symptoms and exacerbation risk. For each of the inhaler types that I go through, there are pretty good videos from the COPD and Foundation and the American Lung Association that we often use for inhaler teaching for each of these devices. And as I mentioned, a lot of these inhalers we walk through, I've circled some example, come as pressurized meter dose inhalers. They're nice because they're compact and portable, um, and people like them the most, but they do have a few disadvantages. Coordination is needed, and there's limited dosing. You often just get a one dose per all of these medication. And common errors are often lack of coordination, patients not holding their breath, patients are not often prepping their inhalers properly. So appropriate teaching is important. And for people who are using these inhalers, a lot of the medicine is often deposited in the oropharynx rather than getting deep into the lung, where you actually want the medication to be. Um, I often will encourage people to use a spacer to help with drug delivery, where you can get up to 3/4, which can, even with small children, you can change the paradigm where you're getting the majority of drug into your lungs. So that's something I push for in almost all of my patients at this point. The other common inhalers are dry powder inhalers, which are these disc. Um, and these are often common for combination inhalers. There are a few types of these. These are often involve a blister or a capsule being punctured by the disc itself prior to using. But these are contingent on an individual being able to take a deep breath in to get the medicine. So I often confirm that my patient understands that, because if they are not able to take a deep enough breath in, they're not actually getting medicines. And some of these require a little bit more coordination than others. This Spiriva HandiHaler, which was one of the historic ones, I try not to use at all because it requires opening a capsule and then puncturing a pill to even prime the device. These elliptas end up being a little bit easier. You may see Brio Ellipta or Trilogy inhaler may be easier for older patients, where they just open it up and they can take a deep breath in. Makes it a little bit easier for people with significant arthritis and things like that. Um, the last thing, if you prescribe someone an inhaler with the name Respimet in it, they may be getting a medicine that comes as a soft or slow mist inhaler. Um, and these work well in terms of getting drugs delivered deep into your lungs, but they also require a lot of coordination with older adults. And I often will have my patients demonstrate how they use them, because they're very challenging to use for people with arthritis. They tend to work better for younger individuals, so I'm often walking through their device. And so this is all my way of emphasizing, even before I change any therapies or add on medicines, I am making sure patients are using their inhalers properly. And I ask my patients fairly explicitly, are you having trouble using your inhaler? And you'll be surprised the number of things people will tell you once primed for that. And then finally, after all of that, that's when I'm finally thinking about ways to step up therapies. And so here, I'm just highlighting the changes that have been made in our COPD guidelines in the past couple of years. There's two pieces. One, under the shortness of breath category, the FDA recently approved a medicine called ensifentrine, which I'll talk a little bit about. They also approved a medicine called Dupixent or dupilumab, which is an injectable drug. And they placed an emphasis on eosinophil count and deciding whether an individual actually needs an inhaled corticosteroid therapy. And I'll talk a little bit about the reasoning for that in a little bit. And we've really transitioned to this approach where we've talked a lot about, we've utilized the eosinophil count as something that's become an increasing part of how we guide COPD care. Because we recognize that COPD within asthma, which is separate from COPD, it's often characterized by high levels of type 2 inflammation and reversibility. And some patients with COPD may have type 2 inflammation, may have higher levels of type 2 inflammation as well. And the eosinophil count can guide that. And people with higher levels of eosinophil are often more likely to exacerbate and this has been demonstrated in multiple population-based cohorts. The eosinophil count has also been associated with a higher likelihood of it responding to inhaled corticosteroid therapy. These are some previous studies that have shown that amongst people with higher eosinophils, particularly uh, particularly those with an eosinophil count greater than an absolute eosinophil count greater than 300, are more likely to have a response to inhaled corticosteroid therapy with a lower exacerbation rate and more improved lung function. But the guide and the use of inhaled corticosteroids may be a little bit more complicated in HIV than the general population. So I emphasize it's important to understand if patients actually need that. Now, inhaled corticosteroids are the backbone for asthma therapy, but the benefit in COPD exacerbations is only in select populations. And these inhaled corticosteroids have been shown to increase risk of bacterial pneumonia for certain subgroups. As you may be aware, that you guys are probably aware, there is an interaction with a lot of the inhaled corticosteroids with certain boosters like ritonavir and cabexistat, particularly with fluticasone, which is utilized in Advair and some other inhalers. So there's been reports of adrenal insufficiency with discontinuation of that. Beclomethasone is the one with the least amount of interactions, but it can be a little bit more complicated to use. So one thing I just want to emphasize to the group, though, is before you're thinking about your drug interactions and their complexities with their ART therapy, I actually think it's important to actually think about whether your patient with COPD actually needs an inhaled corticosteroid. Just because with the pneumonia risk, I think the COPD world has really tried to de-emphasize it where it's not as necessary. So among individuals with low eosinophil count and recurrent infections, we've actually in recent years pushed towards the withdrawal of inhaled corticosteroids, particularly for people who are not exacerbating, because the main benefit for inhaled corticosteroids in COPD specifically is to prevent exacerbations. And this is the framework that's been used within the GOLD guidelines to determine people who would benefit from an ICS and people who we recommend against use for. So people with hospitalizations for exacerbations, people with high eosinophil counts, if you have concomitant asthma, that may benefit use. But if you've had repeated pneumonia events, your patient doesn't have eosinophils, they've even had mycobacterial infections, maybe that's someone who could just do a dual bronchodilator therapy, like a LAMA-LABA, like a Norelipta, where and they can avoid the inhaled corticosteroid altogether. Now, if you have a patient who has an interaction and needs to be on an inhaled corticosteroid, there's a couple combinations you could think about. I'll point out in the U.S. So as I mentioned, beclomethasone or CFAR is a brand name, has the least amount of interactions with ritonavir and cabexistat. So if you want an easier combination, they need to be on triple therapy. You could utilize a Norelipta like LAMA-LABA plus beclomethasone. Stialto plus beclomethasone is an option. There's another one called Bevespi, which is also LAMA-LABA plus beclomethasone. Those are just a few combinations you could think of if you have to do that. I will say in Europe, there is a triple therapy with beclomethasone that's available, and they're trying to get it approved in the US, so that is not currently gone through. But I do want to emphasize before you even go down this pathway, just to make sure they actually even need an inhaled corticosteroid before you're thinking about interactions for a medicine that they may not necessarily need. So jumping on to the next stage in therapeutics, I do want to talk a little bit about the newer drugs that have been recently FDA approved for some of your severe COPD patients. And if you're down this pathway, for the therapies I'm thinking about going forward, I think these are the people where you should really think about just referring them. You should think about referring them to pulmonary, particularly people who are uncontrolled despite triple inhaler therapy. So I mentioned there's been a bigger emphasis in the literature on type 2 inflammation in COPD. So there's the medicine dupilumab or Dupixent, which is every 2 week injectable drug that was used in asthma and atopic dermatitis. Recently had two randomized controlled trials published in the New England Journal that showed benefits in reducing COPD exacerbations and improvements in lung function, particularly in individuals with higher eosinophils and who are symptomatic despite the use of triple therapy. We've in our group experience have seen benefits with this medication so far. That being said, this is a subcutaneous injectable, so it is a little bit complicated to utilize. But I will say that the side effect profile is pretty favorable, and it is not associated with significant immunosuppression. And this drug has become so popular that a lot of pharmaceutical companies have tried to look at other things that target this pathway as well. There have been other things we've thought about for patients with more chronic bronchitis who either may exacerbate or have symptoms. Um, I've circled here a medicine called roflumilast, which you may see on the guidelines, which has been utilized for chronic bronchitis and exacerbations. It is a phosphodiesterase inhibitor that has not been very popular because it is poorly tolerated from a GI therapeutic standpoint. Uh, they did, one of the companies developed a nebulized version of a phosphodiesterase 3 and 4 inhibitor called ensifentrine, which helps to bronchodilate or open the smooth airways, decrease inflammation, and help with mucociliary clearance with a better side effect profile. So this was recently tested in two multi-center studies called the ENHANCE trials to assess therapeutic benefit and safety. And these studies showed an improvement in lung function, reduced exacerbations, and improved shortness of breath in select populations. So this is also another option for step-up therapy for individuals who are persistently symptomatic despite a standard inhaler therapy. And again, if this is something that is being considered, I think this is someone who these are patients who would benefit from a referral to pulmonary. But it is exciting to be in a time where we actually have new drugs or new therapies that have been approved after for many years where I feel like our developments have primarily been finding new ways to combine existing inhalers. As you're dealing with management, I think things we're continuously doing is we're adjusting, we're escalating, we're thinking about switching inhaler devices or molecules, which we've talked about. We've considered people where we may de-escalate things like inhaled steroids. We're constantly reviewing their symptoms, shortness of breath, and exacerbation risk. And we're thinking about a lot of these medications have focused on pharmacologic therapies, but there are a lot of non-pharmacologic therapies that's important to assess benefit from. And I'm going to talk a little bit quickly about those to emphasize a few points at the end. But obviously the biggest non-therapeutic options we think about are things like oxygen and pulmonary rehab. I'm going to go quickly with talking about oxygen, but the benefits of oxygen are primarily seen in those people with oxygen saturations less than 90%. And there's been some mortality benefit with that in COPD and improvements in quality of life as well. So one of the therapies that have been shown to improve long-term outcomes in people with COPD. And this has become a key part of the GOLD guidelines. People who are more likely to need oxygen are individuals with a low DLCO or diffusing capacity. So that's why I emphasize the low DLCO on the patient we discussed up front in the beginning. And our patients who are on oxygen, we're actually continuously reassessing whether they still need it or if their oxygen needs increase, because some people may need oxygen after an exacerbation or severe hospitalization. And we, in our clinics, assess whether that need is continuous or continues to be. Pulmonary rehab is one thing I definitely want to mention today because it is one of the better therapies for COPD that's often underutilized. It improves shortness of breath, reduces hospital stays. It's cost effective. It's a 12-week exercise program that has been shown to improve outcomes with people with COPD. It's recommended in the guidelines for anyone with a lung function less than 50% of predicted or GOLD B or higher COPD. So essentially anyone whose exercise is limited due to symptoms. It involves multiple components, including exercise, training, involving strengthening of the muscles, upper and lower extremity muscles associated with breathing, nutrition counseling. It often works as a mental health support group for many patients with COPD. Um, and patients who get into it really seem to enjoy it. The biggest issue is availability of pulmonary rehab facilities ends up being quite low. And the utilization of pulmonary rehab in patients with COPD is about 4% nationwide. So it ends up being fairly low. And within Hopkins, there's one at Bayview, but the waiting list is quite large. So for me, I am often referring people outside of our networks to other pulmonary rehab locations. And there are now resources for pulmonary rehab programs that we are working to share and disseminate to make these options more available for patients because it ends up being a very underutilized resource. So finally, in the remaining time, I've talked a lot about uh, our COPD in the general population. And then I want to talk a little bit about comorbidities and specific considerations for persons living with HIV. Uh, and these points are a couple fold in nature. One is, we're still bearing this out through the data, but obstructive lung disease and HIV may be a unique phenotype. We've seen repeated studies from our local cohorts, nationwide cohorts like the Max and Ys, showing lower DLCO amongst our individuals with COPD and greater levels of emphysema. And as I mentioned, that this DLCO may be predictive of oxygen needs. So potentially a greater need to screen for oxygen and desaturations. And we found that within our SHIELD cohort that HIV and COPD was associated with DLCO impairment even after adjustment for their quantitative CT emphysema, which actually leads us to wonder about other causes of diffusing capacity impairment, whether things like anemia that actually contributes, but a bigger factor that we're investigating more is pulmonary vascular diseases, including things like pulmonary hypertension that can be screened with echocardiography. And other things I just want to emphasize is within the general COPD care, there's been a big focus on screening for appropriate comorbidities and the care and recognition of COPD as a multisystem inflammatory disease, as COPD is an inflammatory condition that can lead to systemic inflammation that's beyond the risk of smoke itself, leading to increased risk for things like ischemic heart disease, osteoporosis, insulin resistance, and other factors that are important for the aging population with HIV. And to further emphasize, most patients with COPD are going to have mild to moderate COPD. And this is from a population-based study, but most patients with COPD are often maybe more likely to die from cardiovascular or lung cancer causes than respiratory complications itself. So we emphasize the importance of screening for appropriate comorbidities that may be contributing to symptoms that may be synergistic with COPD itself. And when we've applied this to HIV specific cohorts, like the Senex cohort, this is a study that it showed that having COPD itself was associated with greater risk for MIs and cardiovascular events. And studies have suggested improvements in COPD care can actually reduce risks for cardiovascular events through the reduction of exacerbation, which can improve the care for other comorbidities as well. Um, there's also been studies that have found overlap in the general population with other comorbidities and the development of emphysema. This is from actually a study we did in the Framingham cohort that showed higher levels of time averaged HOMA-IR as a measure of insulin resistance associated with greater risk for radiographic emphysema over time. And there's some pathophysiology that combines the two with how insulin resistance impacts the small airways. I bring that up as diabetes care and insulin resistance ends up being important for persons living with HIV, but to further emphasize that these comorbidities tend to interact with each other. And the other piece of from a comorbidity perspective I want to emphasize is the appropriate screening for lung cancer. Now, in a study from the Max and Wise cohorts, utilizing the older USPSTF guidelines, where the age cutoff was above 55, uh, suggested that this would have been a poorly sensitive screening criteria for the people who did have lung cancer in the cohorts. To the most part, this has been corrected by the newer guidelines, which suggest a screening at above the age of 50. But when I see people in my clinic, I just make sure that they have age-appropriate cancer screening because this is an important comorbidity and factor to assess for. I have limited time left, so I'm going to skip over a couple of pieces here, but uh, I do mention that I do want to mention quickly that we are a group of COPD providers here who are very focused on the indoor environment. We've done studies of particulate matter or PM 2.5 in the households that have shown very high concentrations of PM 2.5 in Baltimore households, particularly our lower income cohorts of Shielded and Alive for people living with HIV, and those have been associated with symptoms. Most recently, incorporating in the guidelines for people with a lot of household exposures, we have seen benefits from portable air cleaners to improve both risk of COPD exacerbations and symptom burden. So I always ask people in Baltimore about their home environment and potential exposures. And if people have a lot of potential allergen or dust or chemical exposure in the home, I emphasize the use of like a portable air cleaner with a HEPA filter. Um, I do lastly want to mention, and this is that plug that I was going to talk to you about, is that, there have been very few therapies that have been looked at in HIV that have been looked at specifically in emphysema or COPD amongst people living with HIV. Um, there's this ongoing, we're part of an ongoing study or the depth trial, which is doxycycline for emphysema progression to see if that may be a unique therapeutic benefit. So essentially, the theory behind this is that in HIV-associated emphysema, there's higher levels of matrix metalloproteinases, which can lead to the development of emphysema. The group at Cornell demonstrated that the use of doxycycline can be implemented as an MMP inhibitor and to decrease its effect on MMP9 progression over time. And there was an early signal that this could impact your change in your DLCO impairment or worsening of your DLC over time, which is a good surrogate for emphysema itself. So we've recruited a number of participants, but if you have patients who are interested, we are looking for more people with HIV and emphysema and fairly mild smoking history. So individuals who could participate are at least 30, have HIV, and have some emphysema on CT. And they're randomized to either doxycycline or placebo. I will say, as part of this study, I'm a little bit agnostic about the effect overall, but one of the added benefits that is incorporated in that is that they do get a CT scan, which is a low radiation, a low dose CT scan, which sort of can double as a lung cancer screening CT as well. We also do incorporate lung function testing into that. Um, this is our contact information. The contact information for this will be included in the slides if you're interested in. But I would say regardless of this study too, I think you can feel free to contact me if you have any COPD related questions about your patients or any curiosity, or have patients who are interested in research efforts and HIV and lung disease in general. And with that, I know I've gone a little bit long. I'm just going to emphasize my take homes that COPD is a common comorbidity amongst people living with HIV. Therapeutic options for COPD are evolving. There's evaluation of associated comorbidities is important in those with COPD and people living with HIV, and there's a need for further investigation of COPD therapeutics amongst persons living with HIV. With that, just like to thanks for your time and open up to any questions you have in the remaining time. And like I said, if there isn't time today, you can feel free to email me or reach out to me with any questions you might have.
Well, Sarah, thank you so much. That was just amazing and just full of really useful information. Um, I I have one question real quick, and then I see there's a question already from the in the chat. So my question is just, sometimes people have had PFTs a long time ago, and it just keeps getting referred to again. Like, how frequently do you think it should be reassessed? Like, I had one patient who had a PFTs a long time ago, then got admitted with pneumonia, ended up with a lot of oxygen dependence, which I found quite surprising. But then I felt like I had sort of missed the boat in terms of retesting her function prior to that.
Yeah, so that's a great question. I would say there isn't there are not great guidelines for how often you should repeat PFTs. I myself do it whenever there's a clinical change in lung function. Like if they're, for me, if they're telling me that, I used to be able to, walk 2 to 3 blocks. Now I can only walk one block before feeling short of breath, and that's probably a time I would repeat PFTs. Mostly because the biggest thing, it won't just tell you about the change in their FEV1 or their lung function, but if someone has had a change in their exercise capacity,
Mhm.
and their lung function is the same, it tells you to point for other causes. Because a lot of what I do is making sure their COPD is actually what is causing the symptoms. I would say, generally speaking, there's no need to repeat them more than once a year.
Mhm.
That would probably be the most I would do that in case there's a clinical same setting, clinical change. Other than that, we tend to repeat them every 2 years and at the time of diagnosis.
Mm-hmm. Oh, that's great. Then I see a question from Dave Thomas. I'll just read it. Amazing talk. I saw a person on Wednesday who has heart failure with an EF of 15 to 20% and COPD. Shortness of breath is her main complaint. Will PFTs help to sort out whether the shortness of breath is from the COPD? And if so, how do you approach combined treatment with CHF?
Yeah, I would say that, I think you're starting off with some of our harder questions to answer clinically, because that's a perpetual question. I would say, certainly if there's been a delta in their FEV, in their lung function itself, it would be helpful. I would say though, the lung function testing is most helpful once they're euvolemic, when they're in heart failure, because essentially if you've diuresed them and their lung function hasn't changed too much, it's hard to say how that's, if it's fully attributed to their COPD. I and as far as but I do think it's helpful to fully understand things there. The caveat I do want to emphasize though is if someone has a lot of volume in their chest, it can impair the quality of lung function testing. So we often miss the diagnosis of obstructive lung disease in people who are volume overloaded because their forced vital capacity is impaired and it looks like they have a normal ratio. The question of how to approach management, that one's a little
Can I just ask
complicated.
real quick? Does it drop
Yeah,
your DLCO?
it can.
Okay.
Yeah. Yeah,
So
it
you get
can,
a falsely normal ratio with the okay.
yeah, but it can drop your DLCO. It can drop your DLCO as well. Now, if you have like a normal FEV1 and a very low DLCO, that might point towards a more cardiac cause of shortness of breath. As far as the approach to the heart failure management, we emphasize things like making sure they're euvolemic. Um, I There's often debate about pulmonary vasodilators. The thing I want to address up front, I myself do not worry too much about like selective beta blockers. I know people are often afraid of the use of beta blockers. The studies have shown that it may drop your lung function temporarily, but you tend to get used to it and your lung function tends to normalize over time. You can debate whether you should worry about it in people with essentially negligible, like, or in at the mainly a lung transplant stage of COPD. But for the most part, I think they're fairly safe. And preventing heart attacks is a big part of making sure long-term outcomes are important in people with COPD. Dave, I'm not sure if I answered your question there. I know you.
Yeah, it was great. Thank you. That was really terrific. And anecdotally, the patient was just discharged by Dr. Scully, so I could also learn a lot from her discharge summary.
or have some questions about what the heck we were doing. Well, oh, and one other question in the chat was just whether or not that like picture of all the inhalers that you have, if there's like a source for that, because like people come in and you go through their medicines and they're like, oh yeah, I also take inhalers, and if you could like have like a picture, do you know where you got that picture?
Is it okay if I email it to
Yeah,
you or
that's great,
someone,
and I'll
and
put
then
it on,
you can
yeah,
share with the group? Because I would say I do that every time I'm in clinic, because
yeah.
most people don't know what they're taking. So I just in all of our clinic rooms, we have one of those in the drawer, and we just pull it
Mhm.
out and share it with individuals, and makes our lives a lot easier.
No, that's super helpful. I was also going to ask you when we should refer to you, although I think you kind of identified that like that it's after we've done all the basic stuff.
Yeah,
And
I would say we get under referred to though, because I think
okay.
people who are having frequent exacerbations, despite like standard inhalers, I think they could really benefit. And COPD exacerbations, I think we discount them because they're not always the most complicated to take care of in the hospital.
Mhm.
But the real trick is preventing them from happening in the future. And I think that is where we can be more beneficial, because having multiple exacerbations essentially is like the equivalent of having a heart attack for the lungs. And we
Right.
really, I don't want to, sometimes I overpromise our resources, but we certainly try to accommodate.
Yeah, no, that's been my experience too. So I'm mindful that it's 1 o'clock. So thank you so much for this talk. It was really fantastic. This talk was recorded and so will be available. And then I will get that the sheet and put it on the Teams so that everyone can access. And thank you so much and enjoy your time on the left coast.
Yeah. Take care.